Hello and welcome to this lecture about breaking bad news. I'm Dr. Catherine Miles and today we're going to have a very brief overview of some of the things to think about when you're breaking bad news with patients and relatives. And so we're going to think about how we break bad news in the context of ethical principles. We're going to look at the spikes tool, which could be a useful tool to use when breaking bad news. We're going to look at some of the communication skills and consultation skills you can use when breaking bad news to patients and relatives. And I'll give an overview of some of the research that's been conducted in Jordan about breaking bad news. And then we'll finish with an introduction to the concept of palliative care. As this is an online lecture, we won't actually be able to do the case-based discussion today. So breaking bad news to patients is considered to be one of the most complex and difficult communication tasks that a doctor has to undertake. So what actually is bad news? Well, that depends on the patient. Bad news could be any serious or life-threatening or altering diagnosis. Often when we think of bad news, we think of things such as cancer or being told that somebody actually has died if we're the relatives of somebody, perhaps in a road traffic accident, or maybe being told that they don't actually have very long left to live. Or it could be a chronic disease such as heart failure, which does have a limited lifespan to it usually. There are other diagnoses which may be considered bad news, and those might be affected by the culture of the country that the person lives in. For example, there may be some taboo subjects such as infection with HIV and AIDS autoimmune deficiency syndrome, or perhaps epilepsy. And then there are other diagnoses of bad news, such as an illness that may affect fertility and a couple's hopes to have a baby in the future. For some patients, even a disease such as having a thyroid problem or high blood pressure may be considered bad news, in that they will be expected to take medication for a prolonged period and possibly the rest of their life. So different people have different views about what is actually bad news. And the terminology is changing slightly in terms of, we say breaking bad news is what doctors do, but we're now talking more about sharing difficult news. So not necessarily just giving the patient this information, but actually sharing with the patient in a reciprocal manner, a patient-centered manner, and involving the patient. And recognizing that even difficult news may be hard to share with the patient, even if it's not necessarily something we would think of as bad news. So what ethical principles can we use when we are thinking about sharing bad news with relatives and their patients? So this is just a reminder to show you, we need to think about patient autonomy. And in terms of bad news, that's things about giving the patient the choice about receiving the information. We might actually have a patient who chooses not to know their diagnoses. We also talk about patient consent, and it's important for the patient to be aware of what information we are sharing with whom, and have they given us their consent to do so. And patient confidentiality. It's important to keep information about patients confidential unless they have given us permission to share that. Non-maleficence is not doing harm to your patient. And in some instances, some doctors may feel that not telling a patient may be in their best interests. However, that is very difficult to judge as a doctor. We don't want to be causing distress to our patients, but we do want to be doing good to them. We may want to share bad news about a life-threatening illness so that they can prepare, so that maybe they can see somebody and repair a friendship or a relationship that's been broken. Maybe they want to write a will. And always we need to think about justice, about doing what's right for society as a whole, and recognizing that we are not just simple individuals separate from one another, but we are actually part of a wider society and relational networks. And so in Jordan, we know that the main cultural profile is that of a collectivist culture. This means that people often do things together. Decisions are made together rather than by one single individual. And that can be very difficult to then apply these ethical principles, especially when we're thinking about not only the patient, but their relatives and how they feel about a diagnosis of bad news. It can be difficult when the patients think it is, when the relatives think it is their right to be told the diagnosis before the patient and without the patient knowing. So some of the principles of giving bad news, it's important not to break patient confidentiality. If possible, to take permission from your patient as to who you can share their information with and when. And try not to collude with the relatives. So the relatives may come and say, don't tell the patient the diagnosis, but it's important to work out together so that if the patient wants to know, then they do know. And often patients actually do guess what the diagnosis may be, even if no one's actually told them. We also need to not assume we know what is best for the patients, and we need to not assume that not telling them is not good for them. It's not good. So what can we use to help us as we're in a consultation and needing to share some difficult news? Well, the Spikes tool is a helpful tool to go through some steps to prepare ourselves, prepare our patients and their relatives, and then to give that bad news in a slow and somewhat easier, hopefully, way. So it starts with S for setting. It's important to prepare the environment that you're going to be in. Then there's perception. This is finding out what the patient knows already. What do they think they've got? What have they been told already? Invitation is inviting the patient as to how much do they want to know? Do they want to know the diagnosis and how much? And after that, to give a warning before sharing the knowledge, the K, knowledge. And we want to give this knowledge in small pieces. We really need to be aware of our emotional responses and the patient's emotional responses, and being able to show empathy, that we are understanding how the patient may be feeling. And within that, as we support them, to have pauses and times of silence as well, to let them understand and digest the information they've just heard. Then we finally end with summarizing what has been said and being able to give a strategy or a plan for the future. So if we go into these steps in a little more detail, as I said, the setting is really the preparation, preparing yourself. You need to make sure you've got all those notes of the patient's file. Have you really understood the case? Have you got the blood test results that they've coming for, that they want to hear? Have you got the right scan results? Have you got the right information about the treatment possibilities and what may be able to be done for them? And also to prepare the patient and the relatives, if there are relatives with them, to ask them, do you want to have somebody with you as we discuss, for example, these blood test results? It's important to think of the physical environment that you're going to be in. So it is not ideal to give bad news when you're in a public place, for example, a corridor. You want to try to find a quiet office or side room where you won't be interrupted or disturbed. And with that, it's important to turn off your mobile phone or to give it to a secretary or a colleague so that you won't be interrupted by phone calls. Then for perception, as we said, when the patient comes, obviously, if you haven't met them before, you need to introduce yourself, check you've got the right patient, and then find out a little bit about how they are, how have they been, what do they know already. So usually when you're about to give bad news to a patient, they have had some form of investigation or test, and they're coming for those results. So we want to know what does the patient know already. Then we want to invite the patient as to whether they want to know the information. So do they want to know? And if they do, are they the sort of person who likes to know a lot of information in lots of detail, or just wants a general overview? Are they the sort of person who wants to know even if it's bad news? And again, at this point, if the patient doesn't have a relative with them, it can be possible to ask them, would you like somebody to be with you at this time? And to give what we call a warning shot. So that's saying there will be some bad news. I'm sorry, I have some bad news to share, or I'm sorry the test results were not as good as we expected. So that the patient is prepared that you're about to say something that isn't maybe going to be quite where they were hoping the diagnosis would be. Then as you give this knowledge, this information to the patient, you need to give it in small pieces. Okay, we cannot remember lots of information all at once, especially if we've just had a big shock of news that we weren't maybe expecting. So the patient might have lots of different ideas going around their head, and it's important to give the patient time and to give really the key information that they need at this time. It's important to check that the patient has understood what you've said and that you are actually understanding each other. And with that, I would encourage you, if the patient has a diagnosis of cancer, then it can be important to actually use that word rather than say, oh, we found a swelling, or there's a mass, or there's some growth of cells, because that may leave the patient being more confused. And I know in Arabic, the word saratan, cancer, maybe people are fearful of this word. They don't like to be told this word, but I think as you explain in a very gentle way, it is important, if it is a cancer diagnosis, to actually use that word if possible, so that the patient fully understands what you are talking about. And do allow the patient to have time to think about what you've said and to try to process it. So within that, a patient might end up showing emotions. So they might cry, they might get angry, they might be angry at the doctor. Why can't you treat this? Why have I got this disease? They might be angry for all sorts of reasons. And so it's important to listen to patients' concerns, to give them opportunity to share what they are feeling, and to give empathetic responses. So to say, I can see how upsetting this is for you. I understand that you feel that way. Okay, just a word of warning. Don't necessarily say to the patient, I understand what it's like, because it's very difficult to understand being told a cancer diagnosis unless you have gone through that yourself. So if you haven't, then it's trying to give supportive statements saying, I understand this is upsetting. We can understand being told this is upsetting. I understand that you feel in this way. And then, of course, we need to think about summarizing what has been said. It can be helpful to aid recall and to help the patient to remember to actually say things in their own words. So it can be a helpful skill to actually say to the patient, I know this is a big shock. You weren't expecting this news. You know, who is there at home with you when you go home? You know, for example, if there's a daughter or son, you know, how do you think you will tell them what we've said today? What do you think are the main points? Do you want to practice that now? Again, I know in this culture that might seem quite strange, and even in the UK that does feel a little strange to be asking a patient to repeat back what you've said. However, it really helps them to go and remember the main points that you've shared, especially if it's been a big shock. And then, of course, you need to make sure that you've got things in place in case anything goes wrong. So we call that safety netting. And just making sure that the patient knows, you know, if your symptoms worsen, then come back to the clinic or go to the emergency department. If you have any questions, here are the phone numbers of which you can contact the appropriate doctor or maybe support nurse. And to have a plan of when the patient will return, what tests or what procedures will take place after that. So when we're thinking about breaking bad news to patients, it can help to understand the stages of grief. So Dr. Kubler-Ross did work about this, and she suggested 5 stages of grief. So it begins with denial, where the patient thinks, no, this isn't happening to me. They've got the wrong patient. They're denying that this is the case. Then they may feel anger, as I said, frustrated. Why is this happening? You know, why didn't you find this earlier? Maybe even angry at God. Why, God, are you letting this happen to me? That may lead into bargaining of saying, oh, well, you know, if I stop smoking, won't I get better? If I do this, won't I improve? And sort of hoping that things will get better, seeking a way out. That can then be faced with the realization, actually, this is the true diagnosis, for example, for the patient. And that can lead to depression, to feeling sad and hopeless. However, most patients then move through to a stage of acceptance, of accepting that this is the diagnosis, but there is a way forward. And even if it is not the best outcome in terms of a cure, but there is a way forward in terms of some good treatments that may help to give good quality of life for a while longer. So I wanted to share with you now some of the research that's come out of Jordan that I actually did for my master's dissertation, which was looking at really and identifying the needs of Jordanian doctors and patients and relatives in regard to breaking bad news. And the main findings I'll go through are related to consent and autonomy and confidentiality, those ethical principles we talked about, the first disclosure, and also withholding information. So in terms of this research, I asked through open and closed questions on a questionnaire, 59 cancer patients who knew they had cancer, 50 of their relatives, and then 161 doctors, both at the Specialist King Hussein Cancer Centre and at Prince Hamza Hospital. Then in terms of consent, there is a difference between patients and relatives. So 81% of relatives thought the doctor should get their consent before they tell the patient, whereas 81.8% of patients thought the doctor should get the patient's consent before they tell the relatives. So you can see that both the relatives and the patient think the doctor should take their consent before telling the other person. And actually what happened was that in about 35% of cases, then the doctor did ask the patient before telling anyone else. But that actually means that in a large proportion of cases, almost 65%, the doctor isn't getting the patient's consent. And then in terms of first disclosure, this is how does the patient want to be told the news? Well, 62% of patients said they wanted to be told the news by themselves, which is interesting. Personally, I'd want to be told with my relatives. But 22% of patients said they wanted their relatives to be told. They didn't want to be told first. They wanted the doctor to tell the relatives first. And then only 15% wanted to be told with their relatives. So that's what the patients wanted. In terms of what actually happened, only 3% of patients were told by themselves, 42% the relatives were told first before the patient, and in 54% of cases, the patient and relatives were told together. But we can see here that there's quite a large proportion of relatives that are being told before the patient, and potentially without taking the consent of the patient for that to happen. So in terms of first disclosure, only 25% of patients actually got the diagnosis told in the way that they wanted, according to their preference. And then doctors said that the main challenge was that relatives did not want the patient to know the diagnosis. And I think this is quite a common thing within Jordan. It highlights a difference from the Western perspective, in that these relatives have been told the diagnosis before the patient and then tell the doctor not to tell the patient. So 62% of doctors said this was a challenge. And some of the reasons given by relatives for this were that they wanted to protect the patient from having a sudden shock and from the bad news. So one of them said, my mum might die from a heart attack before starting any treatment. Or they wanted to give it in a way that it's not too sudden, in an easy language and an easy way. So actually the relatives saying they felt if they were told first, they could then communicate to the patient the diagnosis in an easier way. So in terms of withholding information, when the relatives knew before the patient, a third of them asked the doctor not to tell the patient. And in that third of cases, 83% of doctors did not tell the patient, whereas 16% did actually go on and tell the patient the diagnosis. In contrary to what patients wanted, so for patients, 93% of patients wanted to know the diagnosis, even if the relatives had been told the diagnosis first. So that's if the relatives had knew the diagnosis and said to the doctor, don't tell the patient. If that scenario happened, 93% of patients wanted the doctor to tell them. So I think that's encouraging for us, that even if relatives ask you not to tell the patient, often the patient actually wants to know. And our duty of care is first and foremost to the patient, which is very similar to a Western perspective. And then in terms of the skills that were highlighted, patients said how important it was, and relatives said, to have an empathetic attitude from the doctor. For them to use a warning shot, as we said, to give that warning, it's going to be bad news, which may reduce that emotional reaction because they're expecting bad news. They were also saying how physical touch needs to be used appropriately. And again, that was a learning need for doctors. And also the importance to find out patients' and relatives' faith, which is different to the Spikes model. That doesn't mention anything about using religious phrases. Another thing that came up from patients and from doctors was managing patients' or relatives' aggression. So as we said, these stages of grief, the patients or relatives may go through anger. And so being prepared and ready to manage that, and knowing and having the skills for that, is very important. And again, it's so important to offer appropriate follow-up. That was seen as a weakness from this research. So I hope this research gives you some insights into why we teach you some of these skills, because actually from real patients and real relatives and from real doctors, these things are so important. And there were two Jordanian doctors, Salam and Salam, who proposed an IGAD framework, which does take into account some of these things that were not mentioned in the spikes tool. So within this, the interview part is really starting off with asking, do they want the relatives present, and facilitating relatives being there, or asking and finding out whether the relatives should be told first before the patient, if the patient would prefer that. And again, finding out, gather, is finding out how much the patient wants to know. So that's very similar to spikes. But the A for assess and achieve is different. The assessing the religious and family influences. So really trying to find out, you know, how important is somebody's faith to them, and whether it's appropriate to use religious terms, whether that will be helpful and comforting to patients and their families, and trying to assess again how much the patient and family want each other to be involved or not in the disclosure of information. And again, achieving rapport, as we said, that empathy is so important. And then the D is very similar to the spikes tool in terms of deciding how much you tell the patient in small pieces, slowly and simply, and again, summarizing. So I think it's very helpful to look at the spikes tool, but also consider some elements from this IGAD framework when you're planning to break bad news to patients and relatives. But what is important to remember is that each patient and their relatives are different. And so even in the same country and culture, you can have big differences between different patients and different relatives. And we really need the skills to discover what the preferences are for this particular patient and their relatives that are in front of me. Breaking bad news is more complex than just following a model, but these models can help us to develop some skills that we can use when we are breaking bad news. And after breaking bad news, if somebody has been told that they have a terminal illness, then it can be helpful to consider palliative care. Now, this is a concept that is really not very well known about here in Jordan, but has taken on a lot more emphasis in the UK and the US. So what is palliative care? Well, palliative care is a speciality that really cares for people who are dying or have been given a terminal diagnosis where there's no cure. So the philosophy really is to focus on the dying rather than trying to cure or save the patient. And many of the people who are at this stage may be given a do not attempt resuscitation order. So that's saying that if they have a heart attack, if their heart stops beating or they stop breathing, then we're not going to do CPR to try to resuscitate them, but we're going to let them die a peaceful death. And also some treatments may be stopped. Obviously not treatments that help with pain, but if there's treatments that maybe the patient does not want anymore, that the side effects are too strong, or actually it's not really making any difference to their life quality or length of life, then they may choose to stop them. So it's really looking at the patient as a whole person and providing psychological and spiritual support as well as the physical. And of course, during this time, it can be important towards the end of life. Patients can have difficulty in breathing, they could have pain. And so still giving medication that can help to make patients as comfortable as possible is important. So palliative care can encompass various layers. It encompasses basically those patients who've been told that they have a terminal diagnosis for which there's no cure, but it also includes those really at the end of life end-of-life care, which may be the last few months of their life, and providing support for that. And then terminal care, which is where they've really only got a few days to hours left to live. So terminal care and end-of-life care come within palliative care. And as we said, it's really managing a patient's symptoms and trying to give them the best quality of life, while also recognizing that this patient is now in a phase where they are dying, and making them as comfortable, as pain-free, and as supported emotionally and psychologically, as well as physically as possible. So those are some resources that you can look at that can be helpful when considering breaking bad news and ethical principles and palliative care. And I also want to say a special thank you to Dr. David Harness, who helped in the preparation of these slides. Thank you so much.